short and also long term. Okay. So transplant, okay. So transplant is the transfer of living organs or tissue from one part of the body to another or from one individual to another. Yeah. So transplant, grafting, dia maksud benda yang sama lah. Ya, jadi kalau kita guna grafting tu biasanya kita refer kepada transfer of the skin. Ya. So usually, occasionally, it requires organ to be transplant from one place to another within the body. Contohnya macam kidney, been relocated to enable them to continue functioning after ureter have been damaged. So that is what we call as auto transplantation. So kalau auto transplantation, it can help the patient to manage severe, long-lasting kidney pain. So that is auto transplantation lah. So it can be transferred lah daripada our body from one part to another part, ataupun daripada orang lain kepada individu lain. So that is what we call as transplant. Okay. So this is the application. Bila nak ada kidney transplant is during end stage renal failure. Kalau heart transplant usually performed when have terminal cardiac failure. Liver transplant when cirrhosis, cancer, cornea dystrophy, pancreas transplant for diabetes, bone marrow for leukemia, for immunodeficiency, small bowel transplant for cancer, skin transplant or grafting tu masa burns. So if you look at the example of disease, mainly this is all end stage lah, bila it's really damage, the organ tu mana cannot function, so we can recommend transplant. Okay. So this is the transplantation immunology. So graft ataupun transplant, it can be classified into this lah, the autograft, isograft, allograft ataupun xenograft. Okay. So autograft ni macam dia cakap lah, dia adalah daripada one part of the body to another. One part of the body to another. So daripada you punya kidney pergi dekat ureter dia contohnya, badan sendiri lah. Isograft is between isogenic individual, maksudnya identical twin lah, yang tak ada without any problematic immune response, it can do isograft. Okay. So allograft is the most common transplant. So this is between genetically different individuals from the same species, maksudnya daripada I nak transfer kepada you contohnya lah. So that is allograft. So xenograft is between members of different species. Contohnya nak ambil daripada monyet ke manusia. So this is actually rapidly rejected, cell mediated rejection lah. Okay. So what is transplant rejection? So transplant rejection, it can be host versus graft ataupun graft versus host. Tengok nombor satu ni adalah host versus graft rejection. So this is when immunocompetent cell in the host reject the graft. So the normal lymphocyte mediated reaction of a host against allogenic or xenogenic cells acquired as a graft or otherwise, which lead to damage and or destruction of the grafted cell. Okay, so this is the common basis of graft rejection. So memang kalau dalam transplant, the major problem adalah rejection, which is rejection ni adalah immune phenomenon. So macam kalau kita nak transfer organ kidney ke heart ke liver ke pancreas, so we may require a generous blood supply because this is essential for their survival in the recipient body. The blood of the recipient, it carries in it many of the tools used by the body in defense against the foreign substance. So, as the blood is drained from the transplanted organ into the host's general circulation, the body will recognize the transplanted tissue cells as foreign invaders atau antigens. So, it immediately set up immune response by producing antibodies. So, that's why it's rejection. Macam ada certain transplantation it's easily done successfully. Contohnya macam kalau transplantation of the cornea, because the vascular supply is not involved, ataupun grafting of the skin ataupun bone, because the transplant can serve as a structural foundation. Tapi kalau intact organs, it involve blood supply. So rejection is one of the major problems lah. Okay. So acute rejection is caused by the circulating antibodies, which is the result of multiple pregnancy or transfusion or improper blood type matching. So the antibody will react with antigens on the surface of the cells and block good circulation, so the graft not succeed. So first set rejection we can see between 11 to 17 days. Kita monitor lah with the any rejection. And chronic rejection will occur for months to years. Maybe perhaps earlier tu nampak macam okay, and then after months or years, they have a rejection. Okay. Tadi tu host versus graft. Now is graft versus host. So this is the new transplanted cells regard the recipient body as foreign. So when this happens, the cells attack the recipient's body. So the host is incompetent due to age, disease or immunosuppression. So ni bila graft tu pula yang tak nak pergi dekat host. Okay. This is the immunosuppression required at the time and lifelong. It is usually lifelong. It may stop at certain time and depends on doctor will revise the medication. But for certain transplant, it may require lifelong intake lah. And they may have numerous side effects. So kalau kita tengok dekat this table, this is type of drug. There's a lot of nutrition side effects here. Azathioprine. Nutrition side effects include mouth ulcer, dyspepsia, vomiting, abdominal pain. If you look at these side effects here, it may lead to the poor oral intake of the patient. And then corticosteroid, increased appetite, weight gain, increased protein catabolism, hyperglycemia. So they may need additional supplementation. So if the patient is on steroid, you may expect the patient to have weight gain. Cyclophosphamide, anorexia, weight loss, dry mouth, stomatitis. Cyclosporine, sama juga anorexia, nausea, vomiting, diarrhea, increased loss of magnesium, hyperkalemia. Infliximab, mouth ulcer, yang ni pun stomatitis. So basically, they might experience many nutrition side effects that may interrupt their diet intake. Okay, this is the side effect of immunosuppression. Remember, some of them may take lifelong medication. Okay, ini je. Okay, kita tengok background of transplant. Now let us look at the nutrition pre-transplant. Okay. So the role of dietitian is to correct and optimize the nutrition status, provide education on pre-transplant medical nutrition therapy, and educate on post-transplant nutrition concern. So kita ambil contoh lah orang yang tengah tunggu transplant, liver transplant. Patient with end-stage liver disease, they are waiting for liver transplant. So the patient, while waiting for the organ, the nutritional status may deteriorate. Yeah? So therefore, once malnutrition is diagnosed, effort should be made to correct and prevent further complication. Okay? So here, our role, we want to correct and optimize the nutrition status. So when we diagnose, we identify that the patient is already in malnourished stage, our therapy should include adequate provision of calories, protein, vitamin, mineral, and at the same time, we also look at the underlying complication. Ascites dia macam mana, is there any edema, is it encephalopathy ke, etc. lah. So improvement of nutritional status ni may influence their liver metabolism, muscle function, and also immune status. So this is the case with people with end-stage liver disease. So how about yang ada end-stage kidney disease yang waiting for transplant? So you might also look lah whether dia punya, kalau dia ada malnutrition, why? Is it because of the hemodialysis? They cannot meet the higher protein requirement ke? So our aim is we want to balance, we want to optimize their nutrition status for the preparation for them to undergo the surgery. So that is why when we learn about transplant, ataupun bila kita bukan saja transplant, when we learn about surgical nutrition, we really must understand about the disease itself. So maksudnya kalau kita cakap pasal lung transplant ataupun lung surgery, kita tahulah MNT for respiratory, apa yang kita bagi. Cakap pasal kidney transplant, you really need to go back and read about MNT for kidney disease. So this is the common nutritional diagnosis pre-transplantation. We found that the patient is malnutrition. Malnutrition, involuntary weight loss or underweight, this is common and expected lah. We expected that this happened to our the patient, because usually those who will undergo this transplant is the one with end-stage disease. Kebiasaan lah. So that's the condition lah. Okay. Other common nutrition diagnosis include food and nutrition related knowledge deficit. They don't know that what they need to do to optimize their nutrition. Altered nutrition related lab values, excessive mineral intake. Some of them might be obese, overweight or inactivity. Okay, and also inadequate vitamin or mineral intake. So this is a weight management, the intervention strategies. This is actually back to your MNT for weight management. So diet, including physical activity and behavior. This is our strategy. First is they must control their diet, physical activity, and also behavior. This is number one, the first line treatment if you want to manage your weight. Control your diet. Healthy food, reduce your food intake, reduce your food consumption, balance your diet intake with your physical activity, and then change your behavior and lifestyle. So if this cannot be done, dah try buat tak berjaya juga, then we proceed with pharmacotherapy, might help. And then weight loss surgery ataupun bariatric surgery lah. This is now becomes popular method, kan? People wants to go for bariatric surgery, kan? Because they say that after bariatric surgery akan terus jadi kurus, but however not all people suitable for bariatric surgery lah, They have certain criteria, that allow people to go for bariatric surgery. Okay. So look back at the weight management MNT. So it's comprehensive meal plan, physical activity, and also behavioral therapy. So what is your plan? What is your plan actually? Your comprehensive meal plan, is it you want kalau macam people yang nak pergi bariatric surgery, kan? Orang yang memang dah fit untuk pergi bariatric surgery, dia akan warded lah. So doktor akan, dietitian lah akan plan. Apa dia punya meal plan? Is it 1,000 calorie per day, 1,200 calorie per day? So dia akan plan dekat situ. It's very comprehensive meal plan. You just imagine people yang morbid obesity, makan 1,200 kalori sahaja. It seems like macam impossible lah, kan? I pernah jumpa patient, yang nak pergi bariatric surgery, diet dia adalah extremely low calorie diet. Waktu tu bagi 800 kalori sahaja sehari ya, because ini preparation untuk dia pergi surgery lah, 800 sahaja ya. So basically dia cuma boleh makan 3 kali sehari sahaja, pagi, tengah hari, malam. And memang kontrol kau-kau lah, macam makan bihun sup yang tak ada minyak, portion bihun ayam tu pun tak boleh goreng yang racik tu kan. Memang jaga betul lah. And kalau dekat ward kita akan tengok lah, tak ada tetamu akan di-check lah, visitor datang tak boleh bawa makanan ya, check dalam locker tak ada makanan manis ya. So semua tu macam dia nak control dia punya weight lah ya. So it's actually comprehensive, it depends on the patient, what is the goal. Yeah. And then kalau macam case patient tadi tu, I still remember dia physical activity memang tercakap dah, okay waktu ni nurse akan minta suruh jalan daripada katil dia pergi kat ward hujung sana, jalan setengah jam macam tu. That is the physical activity lah. Yes, manageable lah if it's in the ward lah kan. Kalau kat luar tu susah sikit nak control lah. Ya, ini itu yang tadi tu ekstrim lah ya, because dekat ward yang mana reduce weight for bariatric surgery. But for generally weight management is by reducing calorie intake by 500 to 1000 calorie per day. Okay, and then 45 to 60 minutes exercise most days of the week. Yeah, and then we can teach them on nutrition education, focusing on food labels, portions, resources, meal pattern, cooking, etc. Yeah, and then monitoring and evaluation, duration of visit 6 months or more to achieve weight goals, and maintenance. And this is actually general guideline lah, weight management, medical nutrition therapy for weight management. Apa yang kita kena buat lah. Yeah, we know the rule of thumb. We know that reduce your calorie intake, increase your physical activity. But berapa ramai yang boleh follow benda ni? Okay. So pharmacotherapy for weight management is here. Yeah, this is the drug. Vitamin, diethylpropion, sibutramine, topiramate, zonisamide. Yeah. So if you look at the pharmacotherapy, weight loss medication, they might have side effect here. Side effect itu tentunya common, including tachycardia, palpitation. Yeah. This is include headache, constipation, nausea. Yeah, this is all the side effect that might occur with this weight loss medication. Okay. So tadi dah talking about weight management. Yeah, ni kira it's more like kalau macam orang yang pasal orang yang obesity lah ya. So pre-operation, pre-surgical, kalau dia obese, dia kena reduce weight. We aim for weight reduction so that dia punya during operation and also after surgical tu dia punya wound healing, dia punya recovery and quality of life is better. Yeah? Okay. So now baru tengok specific dekat bariatric surgery. Yeah? Like I mentioned tadi, not all people can go for bariatric surgery. Rasa gemuk sikit kan, nak pergi bariatric surgery lah, duit ada 40,000 dalam bank kan, okay, pergi bariatric surgery. No. Yeah? Ethically no. Yeah? Those who eligible for bariatric surgery is those with BMI more than 40. Maknanya gemuk sikit-sikit macam I kan, tak payah nak pergi bariatric surgery kan. Kalau BMI dah lebih 40, they are eligible for bariatric surgery. Or BMI more than 35 with one or more comorbidities. BMI lebih 35. So what is the comorbidities, including hypertension, ataupun ada diabetes, ataupun ada OSA, ataupun ada abnormal lipids. So they are eligible for bariatric surgery. Okay, so there are few types of bariatric surgery and the expected weight loss is about the same lah. So basically kalau you pergi bariatric surgery, you will lose weight. Cuma tak tahulah, cuma bariatric surgery ni boleh dah lose weight, kalau tak jaga lama-lama boleh dapat berat asal balik. So that is bariatric surgery. So kalau cerita pasal bariatric surgery, before pergi bariatric surgery memang kena lose weight juga. Walaupun tadi tengok pasal bariatric surgery mana kat sini. So sebelum dia pergi weight loss surgery ni, dia dah try diet, physical activity, tak berapa berkesan, farmakoterapi tak berapa berkesan, barulah dia nak pergi, dia decide untuk dapat weight loss surgery. Tapi sebelum dia pergi weight loss surgery, dekat sini dia still kena turunkan berat badan sikit, kontrol makan, sebab nanti after surgery dia akan potong bahagian perut tu kan, untuk kecilkan bahagian perut, tak bend dekat situ. So kalau dia tak, dia kena practice apa yang dia makan macam kat sini lah. Or else nanti kalau kat sini pun dia mesti makan banyak, sebab it can expand. So lama-lama kalau dia tak jaga makan, so dia akan macam dia dah bayar berapa puluh ribu untuk weight loss ni, weight loss surgery, dan dia akan gain weight balik lah. Okay. So the strategy before undergoing bariatric surgery, memang dia still kena control eating dan juga exercise. Same goes to post operation. So weight loss surgery ni is not that macam simply you ada duit you boleh buat. No, you have to maintain that. So it's ethically adalah begitulah memang kena jaga before and after. Okay, so kalau untuk orang yang ada renal yang nak undergo for kidney transplant, so we look back to the MNT for renal. So we know that protein needs increase when on dialysis. So we check lah, we optimize their nutrition kalau patient on dialysis. Do the patient meet the protein requirement or not? Then iodine, potassium and phosphorus restriction varies. So what the sodium intake, and then we look at the fluid restriction. Is there any restriction? And then is the patient is anemic? Do they need additional supplement or not? So that is for renal, how to optimize patients with renal end-stage renal disease who will plan to go for surgical. Okay. And then if for heart patient, so basically we look into the sodium intake. We focus on the cholesterol management, weight management if the patient is overweight or obese, fluid restriction if indicated. So if cardiac cachexia, liberalize the meal plan and consider pharmacotherapy to optimize intake. So for heart disease ni, tengoklah apa condition the patient. Whether dia severely malnourished and underweight ataupun dia adalah overweight. So we manage from this. Kalau dia, if the patient is overweight or obese, so we aim for slightly weight reduction to prepare them for the surgery. However, if the patient is severely malnourished, cachexia, so that's another management lah, weight management to increase, to optimize the nutrition status pula. Okay. So for MNT for liver pula, kalau patient tu for cirrhosis, we can optimize their nutrition by providing sufficient nutrition. Contohnya kita nak bagi dia 4 to 6 small meals, with what is HS? 1500. We will look into dia punya sodium intake, adequate protein. Kalau orang yang non-alcoholic fatty liver disease is weight loss of 3 to 10% of 6 to 12 months. We avoid the sugar sweetened intakes, beverages intake. We avoid simple sugar. We treat the metabolic syndrome, exercise. Basically we refer back to the MNT for liver lah. Apa keperluan untuk cirrhosis and also NFLD ni. Okay. So that is about pre-surgical. So back to the discipline. Apa disease dia, and we look at the issue. Apa yang you kena stress kan, Sebab for liver and for kidney, maybe kita punya priority is different. Usually for kidney, kita punya priority kita tengok dia punya protein. Untuk heart disease, our priority we always look at the fat intake. So our aim is basically we just want to optimize their nutritional status. Malnutrition. So kalau the patient have malnutrition, our goal is to optimize the nutrition status pre-transplantation. So the general patient population, 15 to 60% of them are malnourished. This is common in the clinical setting. We go to the hospital, we can see that about 15%, up to 60% of them are malnourished. So that's why they refer to this. Okay. However, for transplant population, the prevalence is much more higher, with 20% to 80% of them are malnourished, and 50 to 65% is commonly reported. So we can see that the rate of the prevalence of malnutrition among patients, among transplant population is very high. Okay. So this is the impact of malnutrition study in 2009, dated study primarily. So tengok ni adalah dia buat study on pre-liver transplant patient. He compared between non-malnourished and also malnourished patient. You can see that for malnourished patient, this is all significant, p-value dia. For malnourished patient, their length of stay in NICU is 20 days compared to about 5 days among non-malnourished patient.
Non-malnourished.
So the total days in hospital for malnourished is about 41 days as compared to only 18 days for non-malnourished patient.
Nak berak ke?
And those high in infection is 4.5 times in malnourished compared to only 0.6 in non-malnourished. So you can see that the impact of malnutrition among transplant patients is they will increase the length of stay in NICU, increase total days in hospital, and also increase rate of infection. So that's why we want to optimize their nutrition status prior to the transplant. Okay. So how do we diagnose the malnutrition? So there are many definitions of malnutrition, and there are few diagnosis criteria. So basically, malnutrition is characterized by insufficient energy intake, significant weight loss, loss of muscle mass, loss of subcutaneous fat, localized or generalized fluid accumulation, and diminished functional status by measured hand grip strength. So kalau nampak orang tu memang tengok dah tak ada makan tak cukup, badan weight loss, cachexia, nampak sangat kurus semua tu. So that is diagnosis of malnutrition lah. Okay. So bila kita nak diagnose malnutrition, this is the criteria, and of course you will have a checklist lah. You ada tools yang you akan guna. So you all dah belajar nutrition assessment, you know how to assess malnutrition. You boleh guna SGA, you boleh guna MUST, you boleh guna kalau dekat ICU, you boleh guna Nutri-Score, etc. lah, apa yang ada available dekat hospital lah.
Progress kita
Kalau
data
goal
collection
study is
dah siap.
SGA lah untuk tengok.
Buat ada. Progress buat ada.
How about albumin and pre-albumin?
Albumin and
So
pre-albumin.
albumin, pre-albumin in diagnosing malnutrition, there's a debate, controversial sikit lah, banyak paper you all boleh baca. However, it actually cannot be used to identify malnutrition. We cannot indicate lah kalau ada low albumin, we can say that the patient is malnutrition. No, because their level is greatly affected by infection, inflammation, recent trauma, renal failure, dialysis, fluid retention, hepatic dysfunction, and it also reflects the severity of illness, not necessarily nutritional status. So failure of serum level to increase with nutrition support doesn't necessarily indicate inadequate nutrition. So inflammation-induced anorexia, reducing the likelihood that the patient will consume adequate nutrition. Okay, so that is about malnutrition during pre-transplantation. Okay, so I hope that you are clear now. Pre-transplant, our aim is to optimize the nutrition status. Okay, so now let us look at the nutrition during acute post-transplant phase. Post-transplant. Okay, so this is a short-term transplant nutrient needs. Basically, we increase the calorie. Calories at least 30 kilograms post-transplant. And you can see that the protein is high. the protein requirement increase from 1.5 to 2 gram per kilogram body weight. Okay, ya, nampak kat sini kita stress on protein and also calories. Calories is slightly higher. Okay, so regular diet for most cases. It means that if the patient can take regular diet, then proceed with regular diet. However, diet restriction as needed depends on the condition, depends on the depends, tengok dia punya biochemical value, tengok dia punya underlying disease. Yeah. So that's when we apply the diet restriction and supplementation as needed. Okay, clear kat sini ya. Kita increase dia punya protein. Kenapa? We know lah that's because pre-transplant kan. So it's for wound healing, yeah, for optimal nutrition. So that's why this is a general recommendation. Okay. So other part tu tengok apa condition dia waktu tu. Okay. So role of enteral and parenteral nutrition. So goal of therapy is to optimize nutrition status. So timely nutrition assessment and intervention in organ transplant recipients may improve outcomes surrounding transplantation. So if the gut works, use it. Still applies as to the general population. So kalau the patient can take orally, then go for orally. If the patient cannot take oral intake, so if the gut still function, then we use enteral feeding. Yeah? Because enteral nutrition is the most cost-effective and decreased risk of complication. However, if the patient the gut cannot function, ataupun it's very suboptimal ke kan, so then we can move to parenteral nutrition together with enteral nutrition. Okay. So enteral nutrition, we should initiate them early. 24 to 48 hours of admission to ICU, because study have evidence. They say that when we initiate in early enteral nutrition, it will decrease the length of stay, decrease days on ventilation support, it maintains gut integrity and therefore reduce risk of post-op ileus, improve the overall nutrient delivery and also promotes wound healing. So initiate is early. Dan nampak patient tak bangun, dia tak boleh bangun kan, patient still on intubate ke kan, so patient tak boleh makan, tak boleh bangun, so we start enteral nutrition as early as possible, within the 24 hours too, because of this. Okay, so for certain condition, enteral nutrition may not be possible, so we opt for parenteral nutrition, which may be indicated for those post-op ileus, intestinal fistulas, uncontrolled nausea and vomiting, those with intestinal failure, severe pancreatitis, and also ascites, so we can consider parenteral nutrition. This will always be decided by the medical doctor lah. Okay, that is for acute. For acute, basically kita tengok kita punya goal adalah sama juga macam pre, we want to optimize the nutritional status. We look at the calorie and also protein. We recommend high protein intake to optimize for the wound healing. Okay, so cakap pasal acute, kita tengok tadi tu on enteral and also parenteral nutrition. And now let us look at the long-term transplant nutrition concern. Okay, so the focus of nutrition education include foodborne illness. Okay, kenapa foodborne illness? Because we need to also teach the patient about the food safety. About the want to prevent them from foodborne lah, because those post transplant they are more susceptible to foodborne illness. So sometimes we recommend on neutropenic diet. So that is why that is our focus lah, kita ajar dia macam ni cara nak makan, cara food safety lah. Okay, and then weight gain and obesity. This is also common post-transplant, maybe because of they feel that they are healthier, kan, they improve their quality of life, so they eat a lot, ataupun it can be to the medication, so it can be the issue juga, And then hypertension and cardiovascular disease also relates to those post-transplant patient. Diabetes, hypophosphatemia, and also bone disease. Okay. Okay, so look at your weight gain. Yeah. So patients gain an average about 3 to 10 kilogram following kidney transplant. Weight gain of more than 20% 1 year post-transplant is associated with an increase in infections and mortality. Yeah. So why weight gain after transplant? The contributing factors include corticosteroid. Kan tadi kita tengok kan side effect of the corticosteroid is weight gain. So improve well-being, they feel happy. They feel their quality of life is better. Dulu tak boleh pergi kenduri sangat, sekarang boleh pergi kenduri, boleh pergi holiday kan. Happy lah kan. And then decrease physical activity. Some of them might feel afraid to exercise. Can be memang tak buat apa-apa kan, duduk je. So it can contribute to weight gain. Genetics, age, race, and also sex as well. Okay. In diabetes, 20% of post-kidney transplant patient also develop new onset of diabetes. Dyslipidemia occurs in 60% post-kidney transplant patient, with 73% of heart transplant patient 1 year post-op and 91% of at 5 years. So nampak after post-transplant they might have other issue as well. So this is so that is why bila after post-transplant bila patient ni lepas transplant they might not see dietitian tau. Mungkin dia akan jumpa sekali saja untuk educate them for diet post-transplant, and usually apa yang tengok dietitian akan fokus on high protein diet lah after transplant. But remember that we also need to teach at least give an idea to the patient what is their nutrition requirement for long term, because shown that post-transplant patient after few years they have high risk to get diabetes, dyslipidemia and also weight gain. So we need to get them aware about all these kind of disease lah. Okay. So this is our objective. Post-transplant nutrition is to promote good nutritional status for the prevention of obesity, hypertension, and also dyslipidemia. Good glycemic control, prevention of bone disease, prevention of foodborne illness, and prevention of nutrient deficiencies. So this is our aim. Okay, datang je patient dekat you, apa nak bagi tahu kat patient ni tak? Kita memang kita ajar dia waktu tu tapi kalau contohlah kata okay, tuan baru lepas transplant transplant heart jadi kena kita suggest on increase protein intake because this can improve your healing. Dan you tak cakap untuk improve untuk high protein sampai bila dia buat dia makan sampai bila kan, banyak je makan kan, lama-lama dapat masalah lain pula. That's the example lah. So that's why you need to say okay, yang ni untuk berapa lama dalam masa 3 bulan ni, contoh dalam 1 bulan ni kena increase protein intake. Nanti kita akan monitor lagi lah sama ada dah okey ataupun belum. Tapi kena ingat lepas post transplant ni selalu dikaitkan dengan masalah apa, jadi kena jagalah so we must educate. If you have time you ada jumpa patient this is among the things that you need to educate the patient. Ada punya post transplant diet education. We educate them on adequate calorie and protein intake, post transplant medication and nutrition related side effect, the food safety and sanitation, and also therapeutic diet as needed. Okay, this is again the medications. Tak apalah, tadi je. Okay. So for long term, tadi short term you akan tengok kalori dia about 30 to 35 and protein about 1.5 to 2, and this is for long term. For long term calories for weight management, you tengok kalori dia apa yang diperlukan untuk maintain their weight if their body weight is normal. Basically we provide them sufficient calorie for weight management, and protein is about normal requirements, about 0.8 to 1 gram per kilogram body weight, and increase with corticosteroid, and 25 to 35% calories from fat, less than 3 gram of sodium, vitamins and minerals sufficiently, and calcium lah. Calcium can supplementation or encourage them to take calcium source as food, milk, for prevention of osteoporosis. Basically, if you look at the long-term transplant nutrient needs, dia punya requirement is just for healthy people. Sama juga macam orang biasa. Okay, so regarding the food safety, food safety is necessary for prevention of foodborne illness. Okay, so transplant recipients are 15 to 20% more susceptible to foodborne illness than the general population. So we recommend on hand washing, sanitation, safe food temperature, food preparation and source of drinking water, and also neutropenic diets. So neutropenic diet ni adalah diets that are designed to lower the risk for foodborne illness. Contohnya, jangan makan, do not eat food that is raw, that is undercooked meat, fish, eggs, dairy products that is unpasteurized, aged cheese, raw fruits and vegetables. So that is neutropenic diet. Avoid eating raw foods lah. And then proper timing and temperature that must be maintained when preparing food. So neutropenic diet ni, other than for post-transplant patient, is also popular among cancer patient, when they receive chemotherapy, or treatment for cancer. So we apply this, we recommend this neutropenic diet as it's apa, kita neutropenic diet dia they pay close attention to food safety kan, which is effective way lah to reduce the risk of exposure to foodborne illness. Okay. So lepas ni I think I might stop until now. Sekarang ni kita boleh berhenti lah sebab we are starting to focus on each discipline, kat renal transplant. So yang ni I akan sambung next sebab ada lagi about 30 slide to focus. Okay, tak banyak lah 30 slide. Lepas ni kita boleh habis dalam masa 1 jam, and then we continue with tutorial saja, about your case study. So okay kan? I tak nak continue lah sebab banyak dah ni. Walaupun I think I can finish this early, tapi nanti tak fokus pula. Okay, so we stop until now. We stop here.